really honored to introduce Dr. David Sheyn. And his research bridges clinical trials, big data, analytics, and AI to improve diagnosis and management of urologic and gynecologic conditions. He has extensive funding support from the NIH and PCORI. His work leverages large-scale data to explore mechanisms and treatment outcomes in pelvic floor disorders, urinary tract infections, and menopausal health. So he'll share data and insights today from the PCORI-funded BELIEVE study. So David?
Thank you for having me. I will say that following all these speakers is really flaring my imposter syndrome. I also can't follow instructions, which is why these slides are green. So I'm going to talk about our trial, which is called BELIEVE because the believer name was taken. So we're comparing two treatments for stress urinary incontinence when we treat pelvic organ prolapse. And this is a nice way to end this day because this is sort of the culmination of all of the basic science that people have talked about that ultimately leads to this and improving our patients' lives. So stress incontinence, I like my job because it's super easy. This is just leakage due to involuntary leakage due to any increase in intra-abdominal pressure that's usually cough, sneeze, laugh, exercise. It's primarily due to injury to the urethral support, but can be due to kind of age-related wear and tear. None of it is normal. And the same risk factors are also related with pelvic organ prolapse. And I have herniation in quotes because it always bugs me when people call it a hernia because it's not a true hernia, but it's the easiest way to understand what's going on. So this is when the uterus, bladder, or rectum herniate through into the vagina and through the opening and can cause significant discomfort due to pressure, bulging, stretching of the introitus, as well as incontinence. And both of these are extremely common. Prolapse surgeries performed in about 200,000 patients. The annual lifetime risk is up to 20% for either one of these conditions for having surgery. 50% of women are affected. Some studies report up to age 65. The day-to-day bother is worse than any other sort of quality of life condition, including arthritis, hernias, et cetera. And yet we sort of treat these less frequently than those conditions. And by 2050, the number of symptomatic prolapse and incontinence is expected to double without a adequate doubling of urogynecologists. And up to 80% of patients who show up with prolapse will all have stress incontinence, and they will seek to treat both of these conditions together. The majority of surgeons will use a sling, so synthetic material that goes around the urethra, and some will come out through the obturator frame, and most will come out in front of the pubic bone. There are some things called mini slings, which are just a single incision, and they don't extend as far into the foramen or through the pubic bone. 600,000 of these surgeries are performed annually in the U.S. alone. And that's just people who come in and complain, so we could be doing 2 or 3 times that number. They are generally extremely safe, 90% improvement at 5 years, over 75 at 15 years, and the majority of patients are dry. Despite being safe, complications can occur, and they include erosion, obstruction of urination, voiding dysfunction, and sexual dysfunction. They're fairly rare, 3 to 5% if done by a fellowship-trained urogyn, even more rare. But they can result in even more morbidity than the original condition, leading to prolonged impairment of quality of life and the need for additional surgery. The most common complication of slings is mesh erosion into the vaginal wall, which can affect sexual function, which is the most important complication, but can also cause infection, bleeding, and discharge. And then this is an erosion into the bladder. So this is the urethra with the cystoscope coming and kind of coming around on itself with a fairly large erosion. These are harder to fix, usually require major surgery, sometimes a partial cystectomy, and a lot of resulting morbidity afterwards. There are some non-mesh options. Some involve suspending the anterior vaginal wall and the urethra along with it. Or you can do a fascial sling, so we make sort of a C-section incision, take a piece of your fascia or sort of down the side of the leg and use that as a sling. Both they are much more morbid. They usually require an overnight hospital stay and have a significant complication rate much higher than that for synthetic slings, up to 20%. In the 80s, someone invented urethral bulking. So this is when you do an injection right at the bladder neck to thicken the urethra, kind of putting collagen in the lips. And this procedure has been performed since the 1980s. However, it wasn't as effective as a sling. And most of these are particulous, a little kind of spheres that we can inject, and they can leach out and go to places that we don't want them to go. This is a CT scan. It's not great, but you can see the sort of the bright spot. This is a coaptite, which is a similar to what is in bone, which is hydroxyapatite that caused obstruction of the bladder. There's no way to remove this. You basically have to excise it and then reconnect the urethra, and that is just not great. Even if it works, it only works for up to 2 years and can sometimes cause even gnarlier complications. But in the early 2000s in Europe, someone invented polyacrylamide hydrogel. So this is 2% polyacrylamide and 98% water. And it's different than all of the other materials because it's a gel versus the other ones are particulate. And this was introduced in the States in the 2020. I still remember I was in Tennessee at our national conference, and they had it there before it was even introduced, and I played around with it. I'm like, we have to have this. So I think we were one of the first sites to introduce this in the States. Because it's non-particulate and porous, it allows fibroblasts to go through the material and create a tissue matrix, so that improves its longevity. Overall, the success is up to 70%. So what we call success is at least 90% improvement in subjective symptoms. It has no major complications and requires reinjection anywhere between 1 and 7 years. There is very limited data, like everything else in pelvic floor disorders. There was one single study that was a randomized trial up to 36 months of a polyacrylamide gel and slings. It was a very well-designed study, but overall satisfaction was highest with the sling, like almost twice as high compared to bulking. And we looked at quality of life and sexual function. At 36 months, satisfaction for the slings remained similar, but weirdly, the bulking satisfaction went up. Even though it was found to be inferior to the sling, both groups reported significant improvement in their quality of life. What do patients want? So patients don't want complications. All of us, when we do procedures, we want to make their life better and have them go away and never complain to us. That's not the case with these sort of chronic conditions. The UK, which is a little bit of a biased sample because everyone that still considers King Charles their head of state, has basically banned mesh. So in the United Kingdom, Australia, Canada, they don't use a lot of synthetic mesh. So they basically do procedures that we used to do in the early 1900s. And patients do sort of want kind of a hierarchical treatment pathway. They don't want to go straight to major surgery. They don't want to avoid complications. They are willing to sacrifice durability and efficacy for safety. So they want something that's safe and that's almost as good. Preferably, they'd want something that's safe and effective and just as good as a sling. The majority of any sort of research on this has always been done for incontinence alone. And that's important because when you fix prolapse, up to 30 to 40% of women will have their incontinence also get better just from correcting the anatomy. However, very few surgeons and even fewer patients are willing to do a staged procedure. They want to correct both things at the same time. So if we can identify sort of a nice bridging procedure that minimizes risk and lasts for a long lifespan of a woman, then we can really kind of solve this problem. The other kind of issue with this kind of research is most people focus on dryness. So that's not necessarily the outcome that we want, because you can be dry and because you can't pee. So what we want is happiness. How happy are you with the treatment? How good is your quality of life? Are you willing to have a procedure that you can maybe have to repeat in 7 years in the office without having a surgery and potential risks related to that? So we came up with this hypothesis, and this came from talking to patients just in the office. This is a great way to conduct kind of a qualitative study for PCORI. They will accept this. So we're just like, would you want to have this sort of study? And we wanted to see if gel was non-inferior to slings when we're doing major surgery for prolapse, looking at quality of life after 2 years. And that's the other limitation. Like we want outcomes for a long time, but that's not how we can't get a grant funded for 30 years, unfortunately. So our main aim was to look at non-inferiority at 2 years using something called a long-form urinary distress inventory. This is a multi-question assessment of symptoms plus your quality of life. We also wanted to look at perioperative and long-term or medium-term morbidity, looking at any sort of complication that can occur as a result of these treatments, and other components of quality of life. Sexual function is by far the second most important outcome that we look at beyond the condition that we're treating. We also want to make sure we're not making them worse, and overall that their quality of life has improved after we have operated on them. This study is unique because this is the first time we're sort of using a holistic approach to quality of life compared to other pelvic floor disorder studies, which have been a little more objective measures. We have objective measures in this, but the primary outcomes and a lot of the secondary outcomes are how do you feel about your life after we did this. So this is a double-blind, and we are actively recruiting a double-blinded study, a randomized 1-to-1 non-inferiority trial, comparing slings to this urethral bulking. The patients are blinded. We're doing sham incisions. Don't know how we got that approved or how patients are allowing us to do this. Obviously, the surgeon is aware, but the assessors are not aware. And we have 4 different time points from 1, 6, 12, and 24 months, which is how we typically follow these patients. One interesting thing that we kind of shoehorn in this is a subset of patients will undergo qualitative interviews, both pre and post-op. And I think this is important because to this day, I don't understand why we're not treating these conditions the same way as we treat joints. The day-to-day bother from prolapse and incontinence is actually worse than for a bad knee or a bad hip or even a hernia. And this isn't even just, it's even within women. Like women are more likely to have a joint or a hernia fixed than prolapse. And I think it's just kind of, we want to understand how this bothers them throughout their life so we can just kind of put it out there and say, hey, ask about this and we can then try to address it. And our primary endpoint is obviously the minimally clinically important difference in the UDI score. We have 11 sites all across the country. 50 of the sites, I think at this point it's over 80% of the sites are recruiting. At UH, we began recruiting it in May, and in 5 months we've achieved almost 50% recruitment goal, which is amazing. Again, I think this is more to the patients that they're like, so a lot of the patients, this is why I love my job, will just say, even if this doesn't help me, I want to help others. And that's why they want to participate. Our sample size is pretty big for a surgical trial, almost 500 patients. And our inclusion criteria is broad. Anyone that undergoing a native tissue repair, so repair without mesh or prolapse, is eligible for both procedures, is eligible to be in the study. We're very committed, and so is PCORI, to including racial and ethnic minorities, and at least 30% of them, of our patients, will be in those groups. And this is bolstered by recruitment from both Metro Health and University of New Mexico, which has a very large Native population. One of the big components of our study is the stakeholder advisory. So these are people that help design the study, consists of patients, insurance representatives, our national organizations, and our industry representative. And the patients are sort of the key. Nothing we can do in the study is approved by PCORI until the patients and the stakeholder board is okay with it. And this is led by Dr. Ann Nguyen, who is at the School of Social Work and has been an amazing leader for this component of the study. We also are inviting patients to partner with us on publications, and we're going to select a small group to take with us to conferences and run small groups and roundtables on how to recruit for these sorts of trials. So what is our expected impact? This is the very first randomized trial of slings versus polyacrylamide gel for vaginal prolapse repair. We hope to generate very high quality and patient-centered evidence that will allow surgeons to better inform their patients and hopefully drive guidelines. It promotes value-based and personalized care, which is sort of, I think, missing from medicine in general. It will also improve our understanding of how these conditions affect the quality of life, and I think will help drive further research and understanding that we need more research. Selfishly, I think this will create really great infrastructure within UH because we can create these big stakeholder networks, and I think we've already seen that across the system. But to be fair, I don't think this project could have been done without the support at UH. So to Jordan's point, I think this is an amazing place for investigators to be at. So I want to thank our Urology Institute, without whom we'd also not be able to do this. LSR is our research coordinator who has done an amazing job of rounding up all the surgeons and investigators. Adonis Hijaz has been my mentor from residency to now. Cecile Ferrando is my co-PI at University of California in San Diego, and all of my partners in urogynecology. And also, I don't know if Ellie is still here, Eleanor Leahy, corralled very busy surgeons and basically single-handedly submitted this application. And it felt not hard at all, even though like looking at it from this side, it's very hard. So I think, again, thanks to UH and Nelly and everyone in the Research and Education Institute, that I don't think this would have been possible.
Questions? Yes. Right behind you.
First, thank you for caring about this, like truly caring. My question has more to do, as the engineer in me, about the root cause. And in working with you even recently on some other projects, it's my understanding that some of this is caused by childbirth. So my question is more about why, at what point do we see the standardization of pelvic floor therapy for any woman who's given birth to a child? Because I wonder, I have a curiosity if, and I know that at UH a couple years, or maybe it was last year, I saw that for women who have had traumatic births that we would deploy that care after, but I would argue that everyone who's given birth to a child is traumatic to your body. So similar to the orthopedics case, I just have this curiosity. And if you don't have the answer, I at least wanted to have a moment to like say it out loud, or maybe I'm wrong. Tell me I'm wrong.
There is a smattering of an answer. So France actually has this program. Anyone, it doesn't matter where you're from. If you deliver in France, you go to physical therapy for 16 visits after every childbirth. Singapore is something similar. I think you have to pay like $180 for the whole thing. Nowhere else. It does help. The root cause partially is childbirth. It's pelvic trauma. So for prolapse and incontinence, when I had pictures. I didn't want to scare anybody, so I didn't put them on there. But the pelvic floor stretches to 250% of its natural alignment, which is like not normal. And depending on how long your birth is, especially the second stage of labor, that can cause significant trauma. And that not only causes muscle injury, causes denervation injury, but the ultimate result is the repetitive strain that the pelvis is supposed to experience just with upright walking gets transferred to the connective tissue, which is not meant to sustain this repeated strain over time. So the prolapse and incontinence is actually a tearing of the connective tissue and the ligaments rather than a lot of people say, well, my muscles are weak, I can just do Kegels. That's not the case. It's like your arm is fractured, I could just do PT and that'll help. So that's partially the root cause. Incontinence is a little tougher. The mechanism for continence, I should preface, I know nothing about male anatomy, so I don't know if it's the same, but in female anatomy, it's very, very delicate. And really any sort of trauma can cause that. There are also genetic predispositions that have to do with collagen turnover. Smoking is another big risk factor because it causes the same sort of tissue stiffness in the pelvis as it does in the lungs. And especially if you have a genetic predisposition to it, the same thing happens. Your ligaments are stiffer, so they'll fracture essentially. To your point, PT, yes, we actually at UH have started an enhanced recovery after delivery clinic. Right now, it's women that have had birth injury, but really anybody should be allowed to go to PT. And there's plenty of reasons besides just this. There's like sexual function, there's pain. We call postpartum like 3 months. It's more like 3 years. So I think people are starting to recognize that and fund that. But we need even more research and sort of more resources. And you can have insurance approve it. You just have to kind of be creative about it.
David,
Yeah.
what is, I know sometimes when I give talks, and especially in Florida, they'll have these clinics that are doing platelet-rich plasma, stem cells for erectile dysfunction. They'll inject into the clitoris, these things. But I am going back to this orthopedic analogy, right? They're trying to use stem cells and other things rather, to actually repair the damage. Is anyone looking at this to actually inject in this area for actually to repair the damaged tissue?
There are. So there's some studies. Adonis actually did some work on stem cells. There was a couple of studies of injecting myocytes into the sphincter And we're actually running a trial for a different condition called interstitial cystitis of using amnion, which is like amniotic tissue to help with tissue regeneration. These are like phase 0 studies. A lot of clinics will do this, and there are some advertised for like urologic conditions, but there's zero data to support it. I think it is promising, but these are really these conditions in particular are mechanical, and I think adding that to a surgical repair will make the repair more long lasting. But just on their own, I don't think that they will be that helpful.
Appreciate it. Okay. All right. Appreciate it. At the end, guys. So first at noon, but pretty much when we step out, please stop by the posters outside. I'll be going till at least 12:30. I do want to just take a moment again to thank the whole UH-RNE team. If you weren't here for that this morning, a big thanks to Yi for getting all of this together and making my life very, very easy. But I do want to, there's some themes today that when you sit and hear all the talks, we went from complex big data from microbiome research, huge amounts of research in metabolism. We're looking at prion disease, kind of across this entire spectrum, olfactory, and the research you just heard. This is something that and I'm not that old, when I was in medical school, there wasn't any of these things being discussed in any meaningful way. And so that is solely because of science and discovery. So in a very short period of time, and I often will reflect, is, when you look at I treat prostate cancer, the first prostate cancers, when they were treated with radiation therapy, they would wheel a patient in a gurney, and they would spread their legs like a woman might be in stirrups, and they would point a cobalt, constantly on radiation source at the perineum, hoping it gets enough dose to the prostate. It cured almost no one. Horrific radiation burns and side effects. And in the 1960s, 70s, we measured survival for prostate cancer at the 6-month mark. Just the other week, I saw one of my patients back when he was diagnosed with a PSA. It's a blood test of 6,000. He had widely metastatic disease. He's now alive 11 years and counting. This is, this is from people dedicating their careers to making these advancements. And I've been getting texts all morning from a gentleman in Hong Kong who's flying out to UH to get his treatment because he is scouring the globe to find he has metastatic disease. It's not curable as of today. He's in desperate hope. And the most fulfilling and gratifying thing, and you can hear from the speakers up how emotional many of them got, why I do what I do when I see a patient, it is the most frustrating thing when you just sit in clinic and you say, I can do what's been done 10,000 times and I know exactly what their outcome will be. When you see a patient with prion disease, you know exactly what the course is effectively going to be, or a glioblastoma or a pancreatic cancer. And so this is the motivation, because sadly, cancer affects, which is why I specialize, 1 in 2 people in your lifetime. It's going to affect you or someone you live with. You add in all the other conditions discussed today, we have to, obviously suffer, unfortunately pass away from something. And so I encourage you to keep pushing, to not give up. And I said this to Jordan Winter earlier, for those that are tennis fans of Roger Federer, and you see these all-time greats, you see the people that spoke up here today, and you're like, I can never do that. Roger Federer won 82% of his matches. And that's what I see when the people come up here. It's like unbelievable. But he actually only won 54% of his points. He lost 46%. He just barely beat, for every, 2 points, he barely beat more than half of those. And so it's about persistence. None of this is going to be easy. You're not going to find the cure to anything overnight. But by being consistent and persistent, he happened to win 1 extra point and won the match. And it ended up, obviously, with his career. So with that, thank you all for coming. Thank you for being engaged. And please go outside. Thank you.